Hi, everyone. Welcome back to another episode of Interpreting in Healthcare, a podcast sponsored by the National Council on Interpreting in Healthcare and prepared by the Standards and Training Committee, which I chair. Hi, I'm Eliana Lobo, and I have a guest that I've been chasing for a little while, but I'm really, really happy he was able to find time in his busy schedule and across 9 time zones for us to meet online and get rolling today. My guest today is Hans Verrept, who is a philologist. He has a degree in Germanic languages from the University of Antwerp and a social and cultural anthropologist from the University of Leuven. He conducted medical anthropological research on health and migration, focusing particularly on the Moroccan community in Belgium, as well as on intercultural mediation in healthcare for the universities of Antwerp and Brussels, their medical departments. Since 1999, Hans has been the head of the Intercultural Mediation and Diversity Management Unit at the Federal Public Service for Health, Food Chain Safety, and Environment in Belgium. Together with his team, he oversees the Belgian program for intercultural mediation in healthcare. In the past, Hans has served as an expert and consultant in developing recommendations for multicultural healthcare for the Council of Europe. In 2019, he authored a report on intercultural mediation in healthcare for the World Health Organization, WHO, in Europe. So, what a distinguished guest. I'm so happy you're here with us today. Welcome, Hans.
Thank you so much for having me, Eliana. It's an honor to be to have a podcast with the National Council. We've been admiring for a very long time.
Well, that makes me happy because I still have people at conferences that are unaware of certifying bodies, certification bodies, and national professional organizations like the National Council. So to have somebody be a fan all the way from Belgium really warms my heart. Um,
Well, that's great to hear that.
You've been doing this for a long time, like me. I just retired last year, but I am still volunteering and putting in my time with National Council. And I don't think I'll be stopping for the foreseeable future because language access matters. Language access matters for everybody, not just the people who can afford to pay extra or bring their own interpreter. I really think for society to function smoothly, it needs to be baked in at all points of interaction. So let's get started with our conversation today. As you look back, how did this all get started? It's so exciting to me to hear about this
Mhm.
intercultural mediation and healthcare program.
Well, that's a very interesting question. The beginning, in a way, the first start, in a way, was an experience by a medical doctor who he was being trained as a medical doctor, and during his internship, he was working at the obstetrics ward in a hospital, and there were many Turkish women there who were delivering babies. And he was so deeply shocked. And the guy is a medical doctor now, and he's working now for the Minister of Health, of Public Health. His name is Guy de Ridder. And he said this was not human, the kind of healthcare that was delivered to those women, because those women, they didn't speak Dutch, they didn't speak English, they only spoke Turkish, and the nurses were yelling at them, and there was no real communication possible at all, and at such a difficult and important moment in life. So it deeply shocked him. And it has been many years later that he started a community primary care center, and there he was also seeing in the city of Ghent very many Turkish patients, and he started working with a Turkish woman who also spoke Dutch. She was not a trained interpreter, not a trained intercultural mediator. But even in this context, he said things were going much better, but we needed trained people who had been qualified to do this kind of work. And that this has been the start of our program in a way. So this was together with an NGO. We developed a program, a training program with internships and everything. And what was important, I think, and it's one of the reasons why we are so fond of the National Council, is that independently from what existed and what had been developed in the US, we developed a model that is very close to the model you have, which takes into account not only linguistic differences, but also pays attention to what I like to call socio-cultural differences and barriers that may impede the process of healthcare delivery. I think part of it is, of course, that the main groups we were trying to provide accessible and high quality healthcare to, the groups we had most problems with in Belgium at the time, with Moroccan and Turkish people. And those came from very rural areas and in general had a very low educational level. And healthcare providers would comment at the time. I was working for a medical department. Healthcare providers would comment on these patients that and say that it was impossible to treat them, to provide treatment for them. And they would get labels like the Malpartout syndrome. So it's something that was still used in France, for instance, not so long ago, the syndrome where you have pain everywhere, or the Mediterranean syndrome, with basically labels that didn't mean anything, but that the healthcare provider was unable to talk to the patient and to grasp what was happening to him or her. And so the model we developed over the years was a model that that focuses. The first step is always language. If you can't communicate with the patient, well, nothing is possible. You are not providing medicine, but you're some kind of veterinary care, which is unacceptable. But we try to take into account health literacy, literacy in general, of course, as well, cultural differences, expectations people may have about healthcare, explanatory models they may be using to explain what is happening to them, their expectations maybe in alternative sectors. And we also try to take into account the existence of, I call it in maybe a euphemistic way, inter-ethnic tensions. That, of course, Europe is not a very welcoming country, and less and less so, I think. And there's a lot of discrimination and racism. And this may have an impact on how patients experience the healthcare encounter, of course, and they may be afraid, and they may think maybe they do not want to take care of us. And there is racism and discrimination in healthcare as well. And we also try to deal or to contribute to the reduction of this phenomenon in the healthcare setting.
What you said about reducing the doctor or the provider's role to being a veterinarian is an example I often use to convince providers and administrators. It's like, look, your providers here are very talented. If they had wanted to be veterinarians, they certainly could have done so, but they
Yeah,
chose to
yeah.
work with people. And if you're going to work with people, you have to be able to communicate. You can't just poke and wait and see if they cry out in pain. That's the vet's job.
Mhm.
And
That's true. Yeah.
it's hard sometimes to get across those barriers unless there are ways for people to experience it. And I'm speaking from working in a very large country of which a surprisingly high percentage speak only one language and have never traveled outside of the United States
Hmm.
from the provider administrative side. So how do we get them to open a window into that experience? There have been some programs. University of Washington had a day of training, one day of
Hmm.
training for their residents where interpreters would come in with somebody else and they would practice scenarios of having a patient that did not speak English. And that gave them
Hmm.
a taste of how to partner with an interpreter. But I think the best feel it in the flesh kind of experience comes from upstate New York, University of Rochester, which has a very well developed ASL
Hmm.
degree program. And what they would do is they would have, again, a day of training for their interns and residents, but the interns and residents would present as the patient, and then everybody serving them was using ASL to communicate. So right away, everyone's having side conversations, they're being asked questions they don't understand, and they feel frozen out of that culture of the clinic and the ability to communicate. And really, those students who underwent that experience have uniformly said it has stuck with them for the rest of their professional life in a way that was profound. And I really wish
Hmm.
we could find a way to insert that into medical school training so that people coming out would not be as unprepared as so many of them are, depending on the specialty. If it's family medicine, you have an appreciative audience that wants to learn how to connect with their patients. But if it's a more refined specialty where they less often have to deal with a patient who doesn't speak the dominant language, it can often be a real struggle to successfully partner in a way that is beneficial, that is patient centered.
Hmm.
So I really wish we could come up with some provider training that would be impactful. What do you look at right now in the present day as your challenges with your program, which is so groundbreaking and so successful? I'm sure there's still things you wish could be better or different.
Well, we only have 60 minutes, so there are quite many of them. I think one of the things, of course, is the point you're just mentioning is how do we convince care providers, and not only medical doctors, but they are a difficult group to reach in our healthcare system, to
Here
make them
too.
understand. Yeah, it's very, very difficult, and to make them understand that they need intercultural mediators or interpreters as well, to provide care that is acceptable, to provide equitable care, to provide care that is safe for the patient and beneficial for the patient. And the thing, the situation doesn't seem to be so very different in Europe from what you're telling. I mean, it's typically something. There's a one-day training on helping patients with a migration background. There's an evening for the medical doctors on diversity management or on interpreting in healthcare. It's always very, very short, very limited. And I do a lot of presentations in hospitals and also in primary care centers about this topic. And the one group that is so often absent is the medical doctor, who's and there's an interesting study that was done. I don't know the exact reference by heart, but a number of years ago in the US, and they found that medical doctors did not feel that it was their responsibility to make real good communication possible with the patient. And that's very disturbing, of course. They think that in a way the patient should fix it, or maybe the authority should fix it. But that's certainly one thing that is very challenging. The other thing that I find extremely challenging these days is the popularity of artificial intelligence and interpreting apps. And we have very little control over what doctors are doing. So I'm working for a federal public service. In many countries, you would call it a ministry. So I'm a civil servant, basically. We What we can do is the authorities could stop funding a certain hospital, but they will never do that for this point, because then there would be a major problem in that region. But it's extremely difficult to convince them how important uh, good communication is. And they are convinced that artificial intelligence or interpreting or translation tools can do the job. And they test them. They test them themselves sometimes, and they take French English or Dutch English as a test case. And for these languages, it works relatively well. but it doesn't work for languages of lesser diffusion. So, and how are we going to prevent that people use this because it's so easy? And we don't have, and it's an advantage you have in the US, I think. You have a tradition of lawsuits when medical errors are made. Of course, it increases the cost of the healthcare system terribly, but we don't have that. And the number of cases where a patient complains because he didn't have access to good communication and maybe even suffers consequences of this poor communication, they're extremely rare in Belgium. So sometimes we try to encourage them to file a complaint, but they don't do it because they find it too cumbersome. They think it will lead to nothing. And yeah,
Or they're afraid of a backlash because they want to be able to continue coming and receive treatment. Yeah, it's very similar to
yeah,
here.
yeah.
I think the best we can do with AI is to try to be at the table during the discussions rather than on launch day of the new product, because I think
Hmm.
there are wonderful things that AI could do right now. Anything that has no nuance whatsoever is still a wonderful way to offload work from the warm body interpreter and free that warm body interpreter to be present for the nuanced situations. So AI is wonderful for wayfinding. Think of all the
Hmm.
museums that you can carry around a device, and each picture that you stop in front of, it explains who painted it, what year, the techniques, and why it's important, or who the contemporary painters were of that area, a load of information. You could have something like that for large campus medical center facilities where people get lost going from one building to another. You could have AI assisted filling out of forms. You
Hmm.
could have AI assisted explanation of diet choices, right? I remember my grandmother in the hospital spoke Italian and Portuguese, didn't know what a club sandwich was. Club.
Uh-huh.
Are they going to hit me with this sandwich? Like, what is this?
Yeah.
So there's a lot that gets asked of interpreting services, and those types of requests, can you walk the patient from such and such to the pharmacy, often don't get filled because we have urgent
Mhm.
requests. But all of them deserve good communication. So why can't we start in the safe areas? I don't want to get into a fight with AI. I want to help guide AI while we process through the literally millions of communication strings that are required for it to develop a robust translation memory. And you're right, for languages of limited diffusion, they are so underrepresented in the development of AI that I would be very hesitant to try and use them for any form of
Mhm.
communication. Just my own experience with having students the last few years, mostly from Afghanistan, whose first language were either Dari or Pashto,
Mhm.
trying to find a dictionary from English to Dari, or a dictionary from English to Pashto and back, to help them learn the medical terms that they need. It's not out there. I found something that the Peace Corps wrote, like a 50-page glossary that included some names of body parts, but I never found an actual publication for reference between those two languages in English. So we have a long way to go, I think, of all the indigenous languages on the planet, as well as the official languages of limited diffusion. And that's a long road ahead. So why can't we partner with the things that we know work well while we give the technology the time it needs to amass the number of words and phrases that it needs to actually develop the language capability that's required in
Mhm.
healthcare or in the courts? I mean, if your pocketbook is at risk, if your freedom is at risk, if your life or health are at risk, we really can't just delegate this off to something that has not been as fully developed as it needs to be.
But
Uh,
I think I had an experience in Japan. I was invited to do a presentation in Japan last year, and there were many people, Japanese people, who were monolingual or nearly monolingual. And I wanted to ask a guy um, whether he was the chairperson of the session where I would be doing a presentation. And he takes his cell phone and he asks me to raise the question, to say the question. And I say, do you think that you would be, will you be the chairperson? And then the answer comes back and he says to me, or the machine says to me, do you need medical help? He
Ah,
thought I had a medical
wheelchair.
problem. So it was really so, and I mean, these are two languages that are well represented on the internet, and it was completely wrong. Eh? And the other thing I'm slightly worried about, I mean, of course, there's going to be companies are going to push their products. They want to sell their product, which is normally, and I completely agree with you, for many situations, very, very simple communication, I think it will be useful. But I think we should be very careful that we do not start using it for those moments where a human presence is so important. I mean, it is already a very technological environment, a hospital. Even when we started with our video remote conference project, we were very worried about adding another machine to the environment. And also the thing, and this may be strange, maybe, and I don't know how people feel about it, but I see that our intercultural mediators sometimes put a hand on the arm of a patient when he's going through a very difficult moment. Also something nice and kind. Uh, and these are important things. It is not true. This is not pure interpreting, but human presence is very important. And in healthcare, it's what patients tell us, that the fact that there was there was one who told me there was the fact that there was an intercultural mediator present during this consultation proves for me that they're really trying to help us. And this means, of course, that they were not too certain that they were going to do the utmost to help them. And when I talk, for instance, with people from Congo, the former Belgian colony, and something we are not proud, we are certainly ashamed of what happened there. I was talking recently to a woman who was being trained as an interpreter, and she said, in our community in Belgium, we try to avoid medical doctors because I'm not too sure that they are really going to help us. I can't say that I don't know whether this is true for the whole Congolese community in Belgium, certainly not. But these feelings exist, and having someone who speaks your language and who's familiar with your culture, it changes so much. And we are firmly convinced that um, the presence of an intercultural mediator, of an interpreter, changes much more even than purely the fact that that sentences can be translated or interpreted. It changes the whole context. People tell much more. They share much more of their life history, of their illness, of everything that is happening to them. And this is so important. And you can't. Well, there's this interesting study that was done in Holland a long time ago. Was that they researched they looked for the duration of a consultation with a patient who didn't speak the language in primary care. And the remarkable finding was that a patient who did not speak Dutch in Holland and came to the GP, the consultation without an interpreter was even shorter than a consultation with a Dutch patient who spoke Dutch, which means
Mhm.
there was hardly any communication at
No
all,
detail.
no detail, and a kind of treatment that is really not, it doesn't uh, answer standards that we want to see met, that have to be met for everybody. I mean, there can be no difference. And this is why it is so important that we have those intercultural mediators, medical interpreters. I think it's very good that in the US you have medical interpreters because it's a special field, it's a specialty, the context is different. And if we don't have them, and we don't have enough of as many as we would need, this is really a big problem. And I think that their AI may help us, as he was saying, to to take away the burden of those very short and very practical communications where AI will probably be able to help us out. I think that will be possible probably in the maybe in the near future for many
What you
languages.
said about the trust, that is so fundamental. I mean, people are in an environment that's new to them. They're not in the country or the community that they are familiar with. The language barrier is scary. Being in an unfamiliar place and facing perhaps some resentment, some racism, also compounds the insecurity and the fear. So being able to connect with someone that hears you, that makes you feel seen and heard, really extends that trust bridge almost all the way to where it meets the provider. That work is done for you, doctor, nurse, and
Hmm.
all you have to do is ask the question and start the conversation. All of the things that people want patients to do, like keep to their appointments, adhere to their medication protocols, follow the recommendations, follow through to see referred specialists. That only happens when the patient first trusts the advice or the
Hmm.
recommendations that are being given. If there is distrust, there's no follow through. And unfortunately, that patient might end up being labeled as non-compliant because they're always late, or they don't
Hmm.
call to cancel, or well, they're not coming back because they're afraid of you, or they don't trust you, or they're suspicious that they're being used in some way and not being cared for. So all of that, I think the human element facilitates greatly. They did a study back in the 60s with infant newly born monkeys, and they had a cage with a doll that was heated with a bottle that the monkey could crawl up on and sleep and have food whenever they wanted. And they had a cage with a wire framed cold,
Hmm.
still with two eyes and a mouth. And those baby monkeys with the wire and the no warmth and the no ability to get cuddled, they all went crazy or failed to thrive and died. So it showed very much how important, even at the very beginning of life, that connection with something warm and alive means. And until we can figure out how AI can do that, I think it has to be a partnership and not
Hmm.
one or the other. It's not an either or kind of thing. The AI tools can help us all be better faster, but are not a substitute, I don't think. At least not yet. I mean, the future is very different and I can't see the future, but we could work towards making the now that much better. And that would also support the development of the AI because it would be put into use. And the more it's used, the better it gets. So,
That's
look,
right. I think the problem may be that at the beginning, I mean, give a boy a new toy. That's a bit of an issue. In you see that many people like it because it's new, and they do not think about all the risks that may be associated with it. I hope that it will never replace human interpreters, because I think that would really be a loss for the quality of care. And also because I think that I'm convinced that the element of trust, which is really at the heart of any medical encounter, that it will not be able to provide this amount of trust, or to
agreed.
contribute to the relationship of trust s- uh, as a human interpreter can. I mean, they are migrant patients, or patients with a migrant background in Europe also are labeled as non-compliant, but it is because maybe they are not convinced that the diagnosis was correct. Maybe they didn't exist the treatment, etc., etc. So I think this is one of the reasons why it is so important to make communication possible, and also to create. And this is something that struck me very much when we were talking to patients, when we were doing assessments of our program, is that patients said, when the interpreter or the intercultural mediator is there, I know that there's someone in the room who can understand my story. I give you an example. In the Moroccan community, people associate, or many Moroccan people in Belgium associate what we would label mental health issues with, for instance, the influence of a demon or a ghost, the so-called jinns. Many medical doctors do not know anything about it, and I remember a case where a woman said that her husband was having a relationship with Aisha Kandisha, which is the name of one of those demons, and this didn't make any sense to the doctor because, in his view, this this man didn't think that this man was having relationships with other women. So a short intervention of the intercultural mediator could give information about the context, the cultural context. Uh, this utterance might be related to. And so they will then explore if this is really the case, what the patient is feeling and is experiencing. So this, I think, and these are things I think taking into account, for instance, explanatory models um, will be very difficult for AI. And the issue is also that many healthcare providers are not at all familiar with the context, the life world of many of the patients they are working with. In Belgium, most of them are white, although it's changing now. For instance, in a city like Brussels, you can find medical doctors with very many different backgrounds, but most of them are still white, middle class people living in a society that knows a relatively high degree of segregation. So they are not familiar with the ways of other people, of other groups, and they may be not be aware so much of how important our own and also their culture is in the interaction and how it may even hamper the smooth delivery of healthcare. I think thinking, for instance, about diets for people diabetics. I had conversations about this is quite a long time ago with doctors who were seeing many Italian patients who used to be. So we had a big Italian immigration in Belgium, and these were miners mainly. They worked in the mines, the men, and many of them would also develop diabetes, and then the doctors would say, "I can't keep them away from the pasta," which was a big complaint. And of course, it's not, the idea should not be to make them eat like Belgians do, but to adapt their diet and make that they eat what they like to eat, but in an adapted way that doesn't harm their health. And this is a very, these were discussions intercultural mediators would have or inform healthcare providers in one-to-one meetings about what is a diet for an Italian person, or what could it be, and what are things how could we discuss this? And even there were even some leaflets made with uh, typical food eaten by Turkish patients, Moroccan patients, to help them. Because if you give them a diet that is completely unfamiliar, people will not stick to it in general. It's because food is so
Absolutely.
central. Food is so central to our identity, and even more in a migration context where there is this experience of discontinuity in your life. And then eating what you used to eat is very important.
They call them comfort foods for a reason. That
That's
comfort
true.
comes from the association of traditions and family members and my grandmother's chicken soup or whatever it is that
Hmm.
you know will fix that flu faster than any medicine. And those beliefs
That's
are
true.
pretty much unshakable. So a lot of our conversation has revolved around the fact that people providing service need to understand the context of the need for language access better. So, looking ahead, what can we do to move that needle? What do you think can be done to, or what's on your mind in terms of looking at the future? Is intercultural mediation in healthcare going to be something that we'll see happening in other EU countries, or will it continue to be Belgium's specialty?
Well, it exists also in Italy and in Spain. There are some smaller projects, but not in the context of healthcare in Portugal as well. But I think more in the context of the police, strangely enough.
Oh,
But they also try. They also have to deal with different groups, and they also experience many problems. Um, I think in Europe there is still a strong influence of the conduit model in anything that you could. Well, we sometimes use the terms social interpreting in Dutch or public health interpreting, not public services interpreting or community interpreting. There are many different terms used. This model is still very strong, although I would say there is some evolution, but still, the idea that an interpreter should only interpret and should not be acting as have a role as a cultural interface or a culture broker or even in certain circumstances an advocate is still very dominant, I think, here. Um, which is one of the reasons why we found and I think the first time I got in touch with the National Council was in 98, probably, of the last century, why we think that the US is, and the National Council in particular, but also the California healthcare interpreters, they also very important to us. They are so important because I think you in a way, you recognize the fact that the context of a medical healthcare encounter is very different from other contexts, and that taking into account cultural issues, taking into account the existence of racism and discrimination also in the context of healthcare may be necessary under certain circumstances. This being said, I think it's very important to take as a starting point always the language barrier. And if we can provide good care, excellent care without doing anything else, I think that's perfect. That's ideal. That's our ideal, because then you respect well the autonomy of the patient and the autonomy of the healthcare provider as much as possible, and both can take up their roles, and that's really what we want. But what we see is that many patients have very low health literacy or feel very ill at ease in the healthcare system. Many healthcare providers, too many, and as you said before, are not trained to deal with people who speak another language or people who are different from themselves, and then we may need a little more. But the main things intercultural mediators are doing, our intercultural mediators are doing, is interpreting. That's the most important role. The other roles, they have to be performed every now and then. But the heart of the intercultural mediation is providing good quality interpretation. Otherwise, that's really the starting point for everything.
That's
But
what's
the open, yeah.
attracted me to healthcare interpreting is the fact that we're all on the same side. We are all, we're patient-centered. Why? Because we're trying to help that patient achieve a better health outcome. Not everyone gets cured. Patients die. Patients you're fond of break your heart. But
Hmm.
we're all on the same side trying to get that patient to a better place. And court interpreting and sometimes business or conference interpreting, that's adversarial. And the
Hmm.
conduit model has to be stuck to very strictly. But this is why I feel that healthcare interpreting is its own speciality, because we don't need to impose the conduit only in all cases. Conduit
Hmm.
works fine if the communication is going back and forth smoothly, routinely, and communicating facts. When there are glitches, we need to be able to step out and check for understanding. We need to be able to ask for further explanation for ourselves or on behalf of the patient. Because if the patient doesn't buy into the recommended course of action, they're not going to show up when they need to show up. They're not going to take their meds as they should. So the understanding coupled with the trust is what leads to really good compliance on the patient.
Hmm.
And that requires us to be able to break out of that silo of conduit model only for the patient's benefit. So
Mhm.
to me,
And
it's
that,
simple, but not
yeah,
to
yeah.
everybody.
But it's also, I mean, when I was doing research on intercultural mediation, that was the very early 90s. And then we came across the work of Joe Cowford, Bob Putsch. And Joe
One of
Cowford
our
is an
founders.
anthropologist.
Yeah.
And, I beg your
Bob
pardon?
Putsch was one of our founders at
Yes,
National
yeah.
Council.
So we
Yeah.
met him. We also invited him once over to Belgium. This was so important because also that they were writing about groups that were culturally very different from the healthcare providers trying to help them. And then you had the whole literature from people like, I think, Angelelli, and I think the other one, I never know how to pronounce it, Hassiye. I think it's a lady of Chinese origin. I
I
don't know
don't
how
know
you
how to pronounce
either.
Chinese names either very
It's
well.
they have so clearly shown how a code of conduct that limits the medical interpreter to a conduit is never followed or rarely followed because people feel that they have to do something more or that it is sometimes even detrimental to stick to this translation machine model. And this has been very helpful for us as well. But I must say that the meetings with Bob Putsch and with Cowford have been really, I wouldn't say eye openers for us. Up to a certain degree, certainly yes. But on the other hand, also we found confirmation for what we were doing, and that was a very good feeling.
It is, isn't it? Like, wow, I thought I was thinking this independently, and here we have people that have done a study and it bears out exactly the conclusions that we came to
Yeah.
on our own. It is such a reaffirmation that you are doing the right thing and are on the right path. And with that, I am so sorry we're going to have to end this podcast. I would like to talk to you for another couple of hours. But thank you so much for your interest and buy-in to the National Council's Code of Ethics and Standards of Practice in enabling you to create such a wonderful program for the people of Belgium. And now, hopefully, those ideas will percolate further out throughout the
Uh,
EU. Thanks so much for joining me today, and I will see all of you again next month at our next podcast. So stay tuned on your platform of choice or find us on YouTube or on the NCIHC website. Thank you, everybody. Bye.
Thank you, Eliana.